Hello, everyone. My name is Ashish Govin. Thank you for joining me today. I'm excited to share insights to an intriguing neurological disorder known as Posterior Reversible Encephalopathy syndrome, or better known as PRES. This disorder is characterized by reversible subcortical brain edema, primarily impacting posterior cerebral hemispheres. The pathophysiology involves disruptions in cerebral autoregulation and endothelial function, leading to vasogenic edema. While we typically categorize PRES into iatrogenic and those associated with medical conditions, it's noteworthy that toxin-induced PRES, especially linked to opioid use, remains a rare phenomenon. Diagnosis hinges on a combination of clinical suspicion and radiological findings. So let's dive into a real life case. A 40-year-old female with a history of hepatitis C, abscesses, and IV drug use came into the emergency department after seizures at a detoxification center. She described having recent fentanyl use and missing Suboxone doses that she was supposed to take. She also reported generalized pain, fatigue, headaches, and sleepiness. Seizures lasting about 3 to 4 minutes involved shaking in limbs without loss of consciousness or urination. Initial vitals in labs indicated hypertension, leukocytosis, and elevated lactic acid. Physical examination revealed weakness, somnolence, and cellulitis. Treatment addressed sepsis, metabolic acidosis, hypertension, and opioid withdrawal. Imaging uncovered hyperdense regions in the posterior cerebrum consistent with PRES. The patient was subsequently stabilized and then discharged back to her detoxification center. Moving on to the images during her stay, on figure 2, we have the CT brain without contrast showing an area of low attenuation in the left occipital lobe, while in figure 1, the more confirmatory test with the MRI brain with and without contrast with T2 and flare sequences showed posterior vasogenic edema in the bilateral occipital lobes, which you can see with the red arrow pointing towards it, and that's consistent with PRES. And figure 3 was our overview of PRES, showing these wide range of risk factors: uncontrolled hypertension, sepsis, acidemia, which was seen in this patient. However, there are many more risk factors with this particular patient of altered mental status, seizures, headaches, visual changes was the clinical presentation, and we did the CT EEG, which was negative for any pathology, and the MRI, which, like I mentioned earlier, was the most reliable and gave us the clearest picture of PRES to have the diagnosis. Moving on to the discussion, the case introduces the complexity, hinting at potential causes from both iatrogenic and medically associated PRES, suggesting a multifactorial origin. Sepsis, a known trigger for neuroinflammation, heightens vascular permeability. Acidosis induces cerebral hyperperfusion and vascular leakage. Elevated blood pressures contribute to increased hydrostatic pressure and extravasation. Notably, chronic opioid use may damage brain parenchyma through increased vascular permeability, endothelial damage, and cerebral dysregulation. So, in conclusion, the diagnosis of PRES, with its non-specific findings, presents a unique challenge. A robust clinical suspicion is paramount for effective management. This case provides a glimpse into the nuanced presentation in a patient with multiple underlying etiologies and a history of substance abuse. As we navigate this challenging neurological syndrome, further research and clinical insights are vital for understanding precise mechanisms and optimizing management strategies. Thank you for listening in on this presentation.